A very good afternoon. I, on behalf of NITRD, welcome you all to today's CTD, NTF, and NITRD collaborative Difficult to Treat TB clinic. I extend a warm welcome to all. I'm Dr. Neeta Singla. I'm Nodal Officer and Head of the Department Trainings at NITRD. On my right is Dr. Rupak Singla. He is Head of the Department TB and Respiratory Diseases in our institute. And on my left is Dr. Sandeep Jain. He will be supporting me in running this clinic. And I'm joined by my support team of ECHO India, Mr. Rahul and Mr. Prateek Negi. It is my pleasure to extend a special welcome to our DDG-TB, our Dr. Rajendra Joshi. He will try to join us, but he has sent his wishes. And I also welcome our presenter for the day, Dr. Gaurav, Dr. Hemant, expert for the day, Dr. Sridhar, and national expert, Dr. Aladi Mohan. I welcome all our participants, state TB officers, directors of NIRT Chennai, NTI Bangalore, director STDCs, faculty of Medical College, district TB officers, and everybody else who has joined us. A very warm welcome. We start proceeding for the day. I request Dr. Rupak Singla to introduce our clinic, and then we can start our case presentation.
Thank you, Dr. Neeta. Very good afternoon to everyone. As you're all aware, this concept of difficult to treat TB clinic was conceptualized by our institute, that is National Institute of TB and Respiratory Diseases. And then with support from Central TB Division and National Task Force together, this clinic was started. And in this clinic, the aim is to discuss the difficult to treat TB cases by the peripheral nodal DRTB centers or the district DRTB centers and provide solution. And also we aim at the capacity building of the medical colleges of the nodal DRTB centers so that they know how to work up these cases and how to discuss these cases and go ahead with this. We started the DTTC clinic in August 20, and so far it is going very smoothly with the help of all of you. And you will be glad to know that as we had thought also that each state should have their own difficult to treat TB clinic. And today I am told that 25 states or union territories, they are having state level difficult to treat TB clinic, which is something we really feel good about it. That means there is a really capacity building of each state. They have their own consultants who discuss the case. And then at national level, we have national level consultants. And in between, whenever we are called, we join the state level clinics and support them. So with these few words, I also welcome our new DDG, Dr. Rajendra Joshi, and we hope that he'll be able to, actually he joined yesterday only, so we can imagine a lot of things on his head. So he said that he will try to join in case it is possible. And I also welcome all the faculty from medical colleges, all the STOs, the DTOs, the nodal DRTB center staff, and all the doctors who are here, including the PG students. So with this, I'll ask Dr. Neeta to start the proceeding for the case today. Thank you all. Thank you very much.
Thank you, Dr. Singla. So today's case is going to be presented by Dr. Gaurav under the guidance of Dr. Hemant Burana. Dr. Hemant is Assistant Professor at Dr. SN Medical College, Jodhpur, which is also a nodal DRTB center. The expert for the case is Dr. R. Sridhar. He is Medical Superintendent at Tamram Hospital. And sir is also Professor and Head of the Department TB and Respiratory Medicines at Stanley Medical College, Chennai. And the national expert for the day will be Dr. Aladi Mohan, who's Head of the Department of Medicine at Sri Venkateshwara Institute of Medical Sciences, Andhra Pradesh. Over to Dr. Gaurav for presentation. Dr. Hemant, are you able to join us if you have any issue, we can share your presentation from here.
Trying to share, ma'am.
Okay, okay. Two of your instruments have been logged. That's why there is interference in the sound. So one of the instruments you will have to either switch off or put the audio off.
Slideshow mode.
Yeah. Please put it on the slideshow mode.
On the next button. नहीं आया ना?
Are you audible, ma'am?
Yes, you are audible, but there's an echo in your voice. There are two instruments logged in the same room.
Now it is okay, ma'am?
And now it is better. Thank you.
Okay. Today I am presenting a case of 26-year-old male resident of Barmer district, Rajasthan. He was admitted at a Cairn Chest Hospital, Jodhpur. Total duration of illness was 4.5 months, approx 4.5 months. He presented with complaint of cough, loss of appetite and weight loss with single episode of hemoptysis. By addiction, patient have no addiction. By occupation, he was initially stone worker for 2 to 3 months. After that, he switched his occupation driver in a factory for 3 years. Family history में no history of contact with a known case of pulmonary TB. No history of treatment for diabetes, hypertension, coronary artery disease, COPD, or asthma. On 10 August 2020, patient was sputum positive, for which HRJD was started and CBNet was sent. In CBNet on 19/10/2020, CBNet showed MTP detected R resistance, for which shorter regime which contain kanamycin, high dose moxiflox, ethionamide, clofazimine, high dose isoniazid, pyrazinamide, and ethambutol was started on 21/10/20. First line LPA and second line LPA was sent. In second line LPA on 28/12/2020, 28 December, second line LPA MTP detected APQ resistance which show GARI3A mutation present or 3BCD not presented with second line injectable sensitive. For this, modify all oral regime which contain bedaquiline, cycloserine, clofazimine, linezolid, high dose moxiflox was started on 30 December 2021. In first line LPA in 6 December, which was not updated at that time. First line LPA so MTP detected, rifampicin sensitive and isoniazid resistance high level. And at the same time, one first line LPA was sent from PHC, which showed on 12 January 2021, first line LPA MTP detected, rifampicin sensitive or isoniazid resistance high level. To confirm it, again, one CBNet was sent on 9 February 21. CBNet so MTP detected or resistance not detected. One CBNet was also sent from PHC, which was not told by the patient. On 10 February 2021, it so MTP detected or resistance not detected. First line LP again sent on 24 February 21. First line LP shows MTP detected, rifampicin sensitive or isoniazid sensitive. After starting all oral regime, patient not reported to DRTB center. This is the X-ray at that time, and the pre-treatment evaluation report shows HB 13.9, TLC 5800, platelet. This and that was the normal. Sodium 129, potassium 4 point, calcium 9.56, and weight at that time was 45 kg, height 155 centimeter. Cardiology reference ECG QTC is 414. Advised QTC monitoring. Psychiatry and ophthalmic reference was normal. Latest results of shows sputum microscopy on 10/8/2020 positive, for which HRJD was started. In CBNet on 19/10/2020, MTP detected or resistance detected. And second line LPA 28/12/2020, 28 December for FQ resistance with Garai mutation 1%, or second line is injectable sensitive. Again, first line LPA send on 11 January and 12 January 21 are sensitive and H high resistance. CAT G2 mutation present, inhibin A mutation absent. CBNet on 9 February and 10 February 21, MTB detected are rifampicin sensitive. First line LPA 24 December 21, MTB detected are resistance and are sensitive and H sensitive detected. Liquid culture DST not available at our center. And during follow-up, sputum culture on 23/6/21, 3-month culture negative. At 5-month culture on 8/9/21 contaminated, and 9-month culture report awaited. And this is a recent chest X-ray of patient. Individual drug sensitivity pattern, rifampicin resistance and levoflox resistance on CBNet in this October and in December respectively. Moxiflox in December 2020 resistance source. Here is our question. Here was a case of MDR PTB R plus FQ resistance on the basis of CBNet and second line LPA. On 19 October and 28 October respectively, patient was started with all oral long regime on 30 January and continued till date. But in first line LPA on 6 January and 12 January, rifampicin sensitive and isoniazid resistance high level detected. And in CBNet on 9 February and 10 February, rifampicin resistance not detected. And also in first line LPA on 28 February 21, rifampicin sensitive and isoniazid sensitive. Now I would like to ask, what should we do for this patient now? Or should we change the regime or continue it? And what could we do if patient came with first line LPA earlier? Thank you.
Thank you, Dr. Gaurav. As the history goes, this is a nightmare for any clinician to manage with such reports coming in from the lab. So I'll just summarize the case. It is already there on your screen. It's a 26-year male. He was put on first line ATT in August 2020. And then on October 20, the CBNAT showed rifampicin resistance and patient was started on MDR-TB regimen. On 28 December, second line LPA showed FQ resistance with high dose high moxi, which was sensitive, fluoroquine resistance, but high dose moxi was sensitive. Patient was shifted to longer oral regimen in January. Subsequently, 5 samples, 3 first line LPA and 2 CBNAT showed patient is RIF sensitive. Also, the samples in January for first line LPA showed high level INH resistance, and in February, patient showed INH sensitive. Patient is now on longer oral regimen since January 21, and issues as listed by Dr. Gaurav is how to manage the patient now. So before I invite our experts for their comment, if there are any questions from the audience, we would, on the history, not on the management, but on the history of this patient, you can ask your questions. Yeah. There are questions, 2 questions on the chat. Dr. Sandeep, can you read it?
The first question is to Dr. Gaurav from Dr. Saroj Kumar Sharma. He is asking, how is the patient doing clinically now?
He is clinically better now, weight increase and no complaint have patient now.
Dr. Gaurav, you have shown both the X-rays, first and current X-ray?
Yes, ma'am.
Second X-ray.
This is the follow-up X-ray. Do you have the initial X-ray?
Yes. And
Okay. And what is the next question?
The second question is from Dr. Ashish Chawla. He has asked that if mutation 3A was present and BCD was absent, why was shorter not continued, which had high dose of moxifloxacin?
Dr. Gaurav, would you like to answer that question?
Initially, initially patient presented to us with R restant and F2 restant. And first line LPA was sent from the periphery, so we could not with a different Niksha ID. So if the patient brought the first line LPA after 4 months of starting of the all oral longer regimen. Ma'am. Hello.
Yeah. You see, whenever you are presence of FQ resistance itself is a contraindication for the shorter regimen. So whenever you have RIF resistance or MDR-TB with FQ resistance present, so that means in that case shorter regimen is not to be given. So they did the right thing by shifting from shorter regimen to longer oral.
Okay. So do we take this case for discussion now? Are there any more questions? You may raise your hands if you want to ask a question. Yeah.
Any suggestion from the DTOs or anyone?
Anything by DTOs? Anybody wants to make any comment or question? Okay, then there is a question. Okay. Dr. Sen Gupta, Dr. Amit, can you ask your question? There is one question by you on the chat.
Actually, I want to know what are the different drugs used in the all oral longer regimen for this particular patient.
Okay, thank you, Dr. Amit. Dr. Gaurav?
yes, ma'am. I will take. In this patient, hello,
Yes, we can hear you.
I am audible now. Modify all oral regime with bedaquiline, cycloserine, clofazimine, linezolid, and high dose moxiflox was started. Hello.
Yeah, we heard that. Thank you.
Okay.
Are there any more questions?
Next question is Batao Sandeep. Yeah, next question is by Dr. Malai Sarkar. Can it be silent mutation picked up by CVNet initially? That is the question.
I think our expert or
Yeah, these questions we will take.
later.
If you have any suggestion how you could have managed the case in this scenario, so let us discuss that. And these kind of, yes, the question is very, very relevant. It will be discussed as the discussion goes on. And we have also microbiologist Dr. Manpreet Bhalla, Dr. Ritu with us. So we will be definitely be discussing these things. Next question is, culture DST was done or not?
No, sir. Culture DST was not done.
Culture DST was not done. This is by Dr. Vishwanath. Then Dr. Jai Kishan has mentioned that in case of genotypic discordance, should we go for phenotypic DST. So again, this will be taken up during the discussion by clinician and the microbiologist. Sir, Dr. Ritu Singhal has answered that yes, there is a possibility that Dr. Ritu, we will discuss this during the discussion part. She has replied to that. Could it be genotypic discordance or could be silent mutation? To that she has answered. So Dr. Ritu Singhal is a senior institute. As we go along the discussion, we will be taking this. Then Dr. Vishwanath has mentioned in such cases WGS should be done. Okay, that's a good suggestion. And again, we'll be discussing this during our discussion. And Dr. Ritu has replied to that, not really.
Now I would request Dr. Sridhar sir to take up the case for discussion.
Yeah, one more thing, just before Dr. Sridhar, one has mentioned that as culture was not available, can it be a case of atypical MTB? Anybody would like to answer this among the audience? Some Dr. Saroj Kumar has mentioned that as culture was not available, can it be a case of atypical MTB? Anybody would like to answer this from the audience?
Sir, this is DTO Udhampur.
Yes.
I think this cannot be atypical because CVNet has given the MTB detection. So if it would have been atypical, this would have not been MTB detection.
Very correct. So I think it should be clear to everyone that whenever the CVNet reports MTB present, that means that rules out the possibility of atypical mycobacteria or NTM. So this one has to keep in mind. And whenever smear is positive, but CVNet shows MTB not present, then definitely we have to think towards NTM or atypical mycobacteria.
Dr. Anand has asked a question, why CBNAT was done during the course of treatment as a follow-up? Dr. Gaurav, would you like to answer that?
Yes, ma'am. When there is a discordance in first line LP and CBNet, according to guideline, there should be two CBNet, two NAAT and nucleic acid amplification test to clarify the situation. That is why again CBNet was sent.
All right. Thank you, Dr. Gaurav. So over to Dr. Sridhar sir now.
Good afternoon. Thank you for the opportunity. I'll be sharing the screen now with few questions in mind. Are you able to hear me, sir?
So we are able to hear you now.
Yeah, fine. Just to recollect, 10th August 2020, the sputum smear was positive, but the CBNAT result is made available only on 19/10/2020, which means there is a 2 months gap, which says that the universal DST is not happening in time. This is a real life scenario in the field level.
Sorry to interrupt you. Are you by any chance giving a presentation also? Have you shared your screen? Because
I have shared my screen. Are you able to see the PPT?
No, sir. We are not able to see.
I'll share the screen again. Are you able to see the screen now, madam?
Yes, sir, we are able to see.
Let's start.
But yeah, it started, but we are not able to see your PPT as yet.
Yeah,
Yeah.
no.
So we can see it now, sir.
Sir, can you go back one slide?
Yeah. I'll do that.
Screen slide show.
So 10th August 2020, the sputum smear was reported as positive, and the CBNAT result was made available only on 19th October 2020, which means almost 2 months gap. So in the programmatic setting, the universal DST is not happening in time. This is one issue. 21/10/2020, shorter MDR regimen was started, and first line LPA and second line LPA was sent. And the second line LPA result is made available only after 2 months, that is 28th December, by which time the patient already has completed 2 months of shorter MDR regimen. This result shows detecting.
Sir, sorry to interrupt you again, sir. We still can't see your PPT.
One second.
Screen is not visible. It's on sharing mode, but it's not visible.
One second.
Slide.
You are able to see now, madam?
Yes, sir. Yes, sir. Just put it on the slide mode, sir.
Yeah,
Slide show.
No, but the moment you put it on slide mode, the screen goes off. So maybe you may continue without slide mode.
1 second.
The left panel can be minimized, sir. You can drag the slider
1
across.
second. Is it okay now, madam?
Yeah.
Perfect, sir.
So to recollect, 2 months later, we are getting the second line LP report, which says FQ resistant.
Sir, फिर से गया.
Aha. 1 second.
सर उसको नहीं दिखना है आज, आप उसको नॉर्मली चलने दीजिए. No problem, sir. This happens, sir. कई बार हो जाता है. Not an issue. जिस भी मोड में चल जाए, it's fine. Yeah. Yeah. That's it, sir. Let's continue it this way. No, it's again gone, sir. Let's do it this way only, sir.
Yeah. No. This is better, sir.
Okay,
Sir,
fine.
please continue like this.
So after this, the modified all-oral regimen with high-dose moxifloxacin as a replacement for levo was started only on 30th January, 1 month from the date of second-line LPA result. One is why there is so much of delay. Second question is why high-dose moxi was preferred instead of the recommended delaminate as the replacement drug. Already the FQ resistance is there unless we know whether it is 0.5 or 1. Using a high-dose moxi has to be justified at that, and the programmatic delay in initiating all-oral regimen could have been prevented for more than a month. Even before the modified all-oral longer regimen could be started on 30th January 2021, we had the first-line LPA report dated 6th January 2021, which shows rifampicin was sensitive, INH had high-level resistance. And 2 CBNATs were done on successive days on 9th February and 10th February, both of which detected MTB, rifampicin resistance not detected. When the patient was already started on all-oral longer regimen based on the earlier result, what was the need for sending 2 consecutive CBNATs on February? And if there was some reason behind that, why no action was taken based on these 2 results? Then on 24th February, the first line LPA results made available, which once again show both INH and rifampicin were sensitive. No regimen change was effected at that stage. And subsequently, we have received the 3rd month culture report on 23rd June, which was negative, and the 5th month culture got contaminated, and the 9th month culture result is awaited. The problems what we are facing in this particular case is reversal to sensitivity from resistance is technically not possible. So the doubt is whether there was any mixing up of sputum samples, whether the lab Nikshay ID of the patient throughout the treatment regimen was cross-checked, whether it belonged to the results or belonged to the same patient, why liquid culture DST could not be arranged as per programmatic recommendations even when the patient was initiated on shorter MDR regimen. Was the serial weight gain and chest X-ray improvement documented while getting continued with the all-oral regimen? If you see Dr. Barona's slide of the latest chest X-ray, even though the upper zone opacity seems to be clearing up, there is a right paracardiac opacity now. So are we facing a situation like fall and rise phenomena? That is $1 million question. Unless we have a liquid culture and DST, we cannot answer all these questions. And other problem is when the patient is on treatment for any follow-up investigation, molecular diagnostic is not recommended. It is based on smear conversion and culture conversion. It is not based on LPA or CBNet. With this, I open the forum for discussion.
Thank you, sir, for that, your comments. And before I invite Dr. Aladi Mohan sir for his comments, I would request Dr. Manpreet, who is the head of the department in microbiology at NITRD, to give her comments on this kind of reports that we get in the field. Dr. Manpreet?
Not unmute myself, Dr. Neeta.
Yeah. Thank you, Dr. Manpreet. Yeah.
Thank you, Dr. Neeta. So as a microbiologist, I would like to give my comments. So to start with, the discordance can be there between different molecular platforms. So to begin with, as Dr. Sridhar said, starting with the sample itself. So with the sample, the first reason could be a human error, that is labeling error, transcription errors, or cross-contamination and specimen mix-up, as Dr. Sridhar said. So that is one of the possibility in case of INH, because it was first resistant high level and then it was sensitive. So beginning with the sample itself, then coming to the different methods. So the different molecular methods which were done in this case were LPA and CBNet. So some of the mutations are picked up by LPA and others are picked up by gene expert. So because of these reasons, there can be a discordance. Then as it was this thing, that there may have been someone asked a question about silent mutations and mixed population. So it is known that in retreatment cases, there is a high possibility of mixed population, and this can lead to discordant results. Then there is a limit of detection for the various tests. Some tests have a higher level of limit of detection. So like in the first test, in this case, CBNet was done and it showed RIF resistant in the first instance. But when it was repeated again, it showed as again repeatedly, it came as RIF sensitive. So this gene expert is known to detect some silent mutations which are may cause misinterpretation and which are not picked up by the phenotypic DST. So the culture should have been is recommended. Culture should have been done to confirm, because usually the silent mutations are not picked up by the phenotypic DST. And also then based on there can be a mixed population. If there's a hetero-resistant population, bacterial population in the sputum, this can also lead to misinterpretation of the probes in case of LPA. So this is what I would like to say from my side. So these are the all possible reasons which can lead to, and so the discordance resolution as per it has to be resolved by sequencing. And sequencing will pick up the silent mutations, and if that means it is to be considered as sensitive, and the patient, even if the CBNet is giving it as RIF resistant, it may be considered not considered. It should be treated as a sensitive case. So that is what I have to say.
Yeah, thank you, Dr. Manpreet. That is indeed very important information from the lab. So we have to think of all the errors that are possible and all kind of mutation that we may face while diagnosing a case. Before I invite Aladi Mohan sir for his comments, I would like to welcome Dr. Diwan, our director, Dr. R.K. Diwan sir. Yeah, Sir, would you like to say a few words?
I'm sorry I joined late today. I was busy in some meeting. All the best. I think the meeting is already well into progress. I'm eager to hear further. Thank you. All the best.
Yeah, thank you, sir. Aladi Mohan, sir, for your comments now.
Very good morning, everyone. Dr. Singla, sir, thank you very much for this opportunity to participate in this important meeting. The case in discussion has brought out several ground realities that exist in the programmatic management of drug-resistant TB. As my esteemed colleague, Dr. Sridhar has very correctly pointed out, the programmatic delays between obtaining the reports of the conventional smear, the molecular report, as well as institution of the regimen, there have been tangible delays which are avoidable. But my concern after going through, I share the same concern as expressed by Dr. Sridhar and Dr. Manpreet with regard to the discordant reports that were obtained at a rather unusual frequency, repeatedly done over a short period in time. My question is, in which laboratory has this been done? Is this a NTEP certified laboratory, or was certification not possible because of COVID and all the other paraphernalia? Because laboratory quality is a very important issue. Now, from a medical college point of view, which are very actively involved in drug-resistant TB management, the most medical colleges are going for the NABH accreditation, not only for the TB diagnostics, but in every laboratory issue, there is what is called quality. Here, I am not clear. I wish to know from the presenter as to which laboratory reported these results. Was it a NTEP certified or a NABH accredited laboratory or not? So that can also explain. So therein, Madam Manpreet has very correctly pointed out labeling error, sample mix-up, and so on. And it has been pointed out that a resistant report cannot suddenly turn into sensitive in the timeline which has been presented. The other issue is there is a when you have the INH-A mutation or when you have the CAT-G gene mutations, this is concerning regarding the low level, high level INH resistance. And if there is in this patient, it is not there, but if there were a CAT-G gene mutation, giving INH would not be possible. In this situation, what does this patient have? Is this patient rifampicin sensitive, rifampicin resistant, INH sensitive, INH resistant? If we look at the number of reports, broadly one can say 2 of the 3 reports indicate it is R sensitive, and 2 of the 3 reports indicate it is H resistant. So can it be considered as a H resistant R sensitive form of drug resistant TB is an issue of concern. The clinical details, there is the QTC interval, we have HBsAg, HCV, and all such reports. But what about the weight, serial weight, which does not require men, material, and money? That data were missing, probably not added to the PowerPoint. And what were the nutritional status of this patient? What was the BMI? What was the diet pattern of this patient? As a clinician, all this would add to considerations with regard to the drug regimens used and the related adverse events or adverse drug reactions. So an issue to consider is whether this drug culture in DST, it was not done. It could have been done. There is a provision in the program, and I think it would have added value for the management of this patient. So this should have been done. And there is a very valuable learning point in the presentation. Given that there is a fluoroquinolone resistance, there is no role for a shorter regimen. So that is a very appropriate way this case has been managed. And in vitro pyrazinamide resistance is very tricky. It is not really reliable. There is also a tangible issue given the composition of a treatment regimen in this case is concerned. So I think the case is a lesson as far as the programmatic delays, both in the report procurement, institution of therapy, and missing clinical data, which could have been provided. And on follow-up is the smear and why the molecular test was repeated. And if it is possible, I would like to know in which laboratory this whole evaluation was done. Was it in one laboratory or many laboratories?
Thank you, sir. Dr. Gaurav, would you like to inform us which lab has done all the tests?
Hello. Ma'am, all test was conducted in the IRL lab, ma'am. And some sample was sent, initially samples, so first line LPA and second line LPA was sent from our institute, and rest sample was sent from PHC, CHC, ma'am.
Okay, thank you, Dr. Gaurav. So now coming to management of such cases, we see that there is a lot of discrepancy as far as the investigations are concerned. But now the question is, how do we manage this patient? Because it's been almost a year that he's taking longer regimen now, or longer regimen. So Dr. Singla, would you like to give your comments on management of this patient?
Yeah, thank you, Dr. Neeta. You see, I'm trying to agree fully 100% with Dr. Sridhar as well as colleague Dr. Ladi Mohan, that emphasis has to be on the universal DST. Whenever we diagnose a patient of TB, immediately at that time only patient should be subjected to the genotypic test to know whether patient is rifampicin sensitive or not, rather than doing it after 2 months when patient is not responding or some other reason. And also we need to follow the national guidelines, which are very, very clear in this case. It's like mathematics. You diagnose a case, if you find rifampicin sensitive or resistance, whatever it is, in both the scenarios, we have to do the first line LPA. Because there are two advantages. If first line LPA is also showing, suppose the CBNet shows RIF resistance and LPA shows RIF sensitive, that means there is a discordance. So in that scenario, we need to put up a third test, which could be CBNet or LPA, reconfirm whether it is rifampicin resistance or not. Simultaneously, clinically evaluate the patient whether he is a high likelihood of drug resistance or not, like retreatment case or whatever it is. And send culture also at the same time, so that whenever culture will come, we will retest it and reconfirm whether, although the guidelines say that if out of 3 tests done, 2 are RIF sensitive, start on RIF sensitive treatment. If 2 are RIF resistant, start on the RIF resistance treatment. That is all right. But simultaneously, we have to clinically very strictly watch the patient, how he or she is responding to whatever decision we have taken. So in this case, you find there have been delays of months, 2 months, 3 months between the CBNet done initially, that was on 19/10/20, and then second line LP after 2 months, which showed FQ resistance, but 3B, 3C, 3D mutation absent, which indicate that high dose moxi can be used, although it is FQ resistance. But first line LP was done on 6/1/21. So by that time, patient has already been shifted to the longer oral regimen from shorter oral regimen. So all these things could have been avoided in case we do this test on time. So we are clear that what appropriate regimen patient should be on. And then regarding the management, first we need to know what we are treating. So as already discussed, here if you find out of the 6 tests, including 2 CBNet and the 3 LPAs, only 1 CBNet has shown RIF resistance and the rest 5 has shown rifampicin being sensitive. So here being done in IRL. So here chances of mix-up, administrative errors, these things are practically, I can say, they are almost negligible. I would like to treat this case as rifampicin sensitive. Coming to INH. The 2 first line LPA done on 6 January and 12 January, they showed H high level resistance, both. And while on February, that is 24th of February, it says H sensitive. So here, as explained by our microbiology colleagues also, here we have to again see whether it is a lab error or what. And also sometimes in case the number of bacteria present in the sample are low, it can also lead to a wrong the wrong decision about the rifampicin resistance. And LPA, we know there is some manual component also. They see the bands and then they decide manually whether it is this particular mutation is present or not, and whether it could be resistance or not. So in this case, because out of the three, 2% LP are showing H high level resistance and one is showing H sensitive, I would like to treat the case as INH high level resistance. So looking at because now we don't have much things with us. Culture was never done. So we have to decide what is to be done with this case and what diagnosis we are contemplating so that we can decide the treatment. So in that case, if we diagnose this case to be rifampicin sensitive and H high level of resistance, in that case, this becomes a H monopoly resistance. And we had only one second-hand LPA which showed FQ resistance, but high dose moxi can be used. Ideally, once we were finding on follow-up that rifampicin was sensitive, even second-hand LPA should have been repeated to really see whether it is FQ resistance or not. If it is FQ resistance, whether it is high level moxi can be given or not. But again, that information is not with us and the baseline culture is not with us. So here, if we respect that the FQ could be resistance, but high level moxi can be used, so it becomes a case of H monopoly resistance with fluoroquinolone resistance with high dose moxi can be used. And we know when we go for the replacement sequence for H monopoly, in these scenarios, the routine treatment is 6 months of fluoroquinolone, rifampicin, pyrazinamide, and ethambutol. But here, if we believe the second-hand LP report done on the 28th of December, we would like to replace levofloxacin by high dose moxi. So all these 11 months from January 1st till date, patient has been on a regimen of so-called longer oral regimen, which consists of bedaquiline, linezolid, in this case high dose moxi, clofazimine, and cycloserine. And patient is, we are told patient is responding clinically. X-ray showed there are fibrotic lesions. And follow-up they found with this regimen, 3rd month culture was negative. Unfortunately, the 5th month culture got contaminated and now the 9th month culture is awaited. So I feel in case the 9th month culture turns out to be negative, I don't mind believing that patient has taken 11 months of treatment and we can even stop the treatment and follow up the case clinically, radiologically, and doing culture so that anytime patient reverts, we are able to catch him. Because using these drugs, these drugs are not only expensive, but they have a lot of adverse drug reactions. So, and especially when patient has taken them for long, they have their own adverse drug reactions, especially linezolid causing peripheral neuropathy, clofazimine causing darkening of the skin, so cycloserine causing the depression. So they have their own adverse drug reaction. So in this case, believing he's rifampicin sensitive and H high level resistance with FQ resistance, I feel we can take a call to stop the treatment at this stage after we have 9th month culture report awaited. If 9th month culture report is negative, then we can believe that whatever treatment was required by the patient that has been given. And these drugs, they are good bactericidal drugs. They have sterilizing action also. So that's my take on this, that we can follow this policy. Thank you.
Yeah, thank you very much, Dr. Singla. Dr. Ritu, you want to make a comment, and Dr. Lokesh Gupta after that.
Actually, ma'am, thank you so much for the opportunity. I've already written on the message. I'm totally in sync with what Dr. Manpreet ma'am is saying, but just wanted to add on one very small point that, in this case, because we are talking about sequencing, if you really see clearly, only in one case CBNAT was resistant, whereas in follow-up CBNAT and LPS is consistently sensitive. So sequencing is a low throughput test, and it's a very, very costly test, more so with whole genome. So rather than going there, we have the answer in front of it. And regarding the second one, in case of INH discrepancy, what we would need to do is just repeat the test once, and based on the consensus, we would find an answer. And regarding the third thing, in case we are seeing a patient who is, not responding to the treatment, but is picking up rifampicin, it's a possibility NTM can be there, because a molecular test will only pick up a specific region. Whereas if you're going to do culture, it is a possibility to be able to find out. So both, all the three things has another take to it, and that can also be seen by clinician in that light. Thank you so much for your time, ma'am.
Thank you, Dr. Ritu. Dr. Lokesh Gupta.
Good afternoon, ma'am.
Good afternoon.
Sir, as you have explained the things, Dr. Singla, sir, if in any case the
Sir, we are not able to hear you. Dr. Lokesh, your audio is gone. Meanwhile, can I ask Dr. Rishi? You have raised your hand, Dr. Rishi.
Sir, in such a case, my question is, in such a case of discordance, if we give, now we have already started giving or oral regimen, but after careful analysis of this case along with culture reports, can we give this patient H monopoly now?
Yeah, you see that may not be required, because why we will shift to H monopoly? Idea is in H monopoly where only INH is resistance, we give REZ along with the fumarole. Keeping in mind there that they are bactericidal and they are sterilizing action. But we know in this regimen what patient has received so far in these 10-11 months. The drugs, they are bactericidal, good bactericidal drugs. They are good sterilizing drugs also. So at this stage, starting the H monopoly regimen, I feel may not be required.
Yeah.
Especially when the current culture turns out to be negative. 3rd month culture was negative. The 5th month culture was contaminated, so no report. In that again will prove that bacteria have already been killed. So that was my point. Some people may argue why not to complete all oral longer regimen. Yes, that could be an argument. But shifting to the H monopoly regimen, I'm not for it. I think that may not be required. Thank you.
Yeah. Thank you, Dr. Singla. Dr. Lokesh, back to you.
Yeah. Sir, almost same question as Dr. Rishi have asked. If in any case, 9-month culture comes to be positive and with the same resistant pattern as the cases, so then we can start H monopoly with moxifloxy high RJD?
No, definitely not. In case culture is positive, that means the current drugs have failed. Then it will be individualized treatment regimen. We have to take the help of this DST, because all these drugs, they have been given for 10 months or more and patient is still culture positive. So in that case, we have to take it different. We have to design a regimen for this. Then H monopoly definitely will not be the answer.
Thank you, Dr. Singla. There are questions. Most of the questions on the chat have been answered. And there are some individual other case histories that are coming up on the chat that you can write a mail to us and we will try to reply your questions. Now, I would just like to inform for today's take-home message for today would be that we should be doing all the investigations timely. We should be following up with the lab for the reports. Sometimes the reports are ready in the lab, but they don't move to the districts. So maybe we need to coordinate better with the labs for the report to give those reports to us on time. And then there is a big role of DRTB committee in all the nodal DRTB center. All such cases, every nodal DRTB center should be having a good committee which should be looking into such difficult cases when they come to them. So I hope the same was done for this case also. So, sir, any remarks from our national expert, Aladi Mohan sir? Any last comments from you before I close the case?
This case is very illustrative of the reality. So whether the delays are tangible, they are common everywhere. It's not necessary in the northwest part of the country. But even down south, it is the same. These are avoidable, and performance of the molecular test, and when required, doing the culture DST as per the protocol. National would help, but the clinical monitoring also has to be very precise. Attention to this patient is very young perhaps, but otherwise attention to comorbid conditions so that the drug-drug interactions and all are taken into consideration. So very valuable teaching learning exercise, madam. Thank you.
Thank you, sir. Sir, today's clinic was a really interesting one because we had the case from Rajasthan. The case expert was from Tamil Nadu. Our national expert was from Andhra Pradesh, and we are discussing the case from Delhi. So this could only be possible with these echo sessions. So thank you for participation and having such an extensive discussion on this case. Now I would request Dr. Ashok Bharadwaj, who's NTF chair, National Task Force chair person. Sir, I would just like to inform you that today we are joined by Madhya Pradesh, then we have Uttar Pradesh, Tripura, then Jammu and Kashmir, Maharashtra, Rajasthan, West Bengal, and Odisha, who have joined us. So it's indeed a very enriching experience. So over to Dr. Ashok for his closing remarks.
Thank you, Neeta. So respected Dr. Diwan, Director NITRD. So following the case right from the start to finish, what is my assessment is that the program guidelines were not followed. I don't think in total, but these were not followed. As also Dr. Rupak told, it is very clear. It is simple mathematics. When you encounter a case, we have to follow as per the national guideline. So where comes CBNet in follow-up? What was the turnaround time for CBNet in the initial stages? So they're all compromised. So and this can be there in other institutions, but we cannot digest it in happening in a medical college. So we must focus on this. We must follow the guidelines, and there will be no problem in dealing with such cases. And as per Dr. Eladi Mohan, so there are DRTB committee or nodal DRTB committee in all the institutions. So we must have their interaction before initiating any treatment guideline, treatment regimen, or as per Dr. Singla told, we have to have a tailor-made regimen for these people. So thank you very much. It was a very interesting case. I listened right from the start. So thank you, Neeta. Thank you, Dr. Rupak, for giving me a chance, and you are doing a wonderful job. So again, I compliment you, the couple, for doing a great work in regularity in having national DRTB clinics. Thank you very much.
Thank you, sir. So we would also like to inform you that we run a thoracic surgery echo session very regularly from our institute, and Dr. Diwan sir, our director, runs those clinics. And tomorrow we have a thoracic surgery clinic at 7 p.m. If anybody is interested, you can write to us and we'll share you all the details regarding that clinic. So thank you for joining us. There are
Neeta, 1 minute. So I also take this opportunity from the National Task Force, the Zonal Task Force, the State Task Force to welcome the new DDG, Dr. Rajendra Joshi, into the program, the National TB Elimination Program, and with his active support, we will be able to achieve the goal of our worthy Prime Minister for ending TB by 2025. Thank you very much.
Thank you, sir. So there are some more questions on the chat, and I think the other people are answering those. And but now that we are crossing our time, I would like to close the clinic now. So I thank everybody who has joined us, and we are floating a feedback questionnaire. Kindly answer it so that we can improve in our next clinic. So kindly answer the poll, and thank you everybody for joining us. Thanks a lot. Kindly answer the poll questions. Any burning question on the chat? So any question that you would like to take up? Please answer the poll questions before you log off. Yeah, we will share the link of thoracic surgery. Can you do it now? Yeah, we are sharing the thoracic surgery clinic link on the chat. Please copy that link. And if somebody is not able to copy, please write a mail. We will definitely send it to you. Yeah, the link is on your chat now. It's a very interesting clinic where the thoracic surgeons from all over the country join and discuss very interesting cases regarding surgery. Only 50% people have answered to our poll, so please keep answering the poll questions. Yes, Dr. Dipesh, we'll send it on your mail. We have noted. We will send it on your mail. Do they need to? You don't need to register for tomorrow's clinic. You can straightway join.
Himachal, Jharkhand also joined.
Okay, so we have Dr. Ashok sir, we have representation from Himachal and Jharkhand. Yeah. Okay. So we close the clinic. Thank you. Thanks a lot.